How you doing, guys? So in this video we're going to talk about a failed knee meniscus surgery repair. Okay, and so right now you had that, how many years ago was that knee surgery?
I think 3 years ago.
3 years ago. Okay, and what's going on now with that left knee?
Well, it's so pain. I can
You're right, kneeling.
Kneeling.
Right, you can't bend it as much.
Yeah, bend.
Okay, so can you do a squat? How much can you do a squat with that knee?
Oh, I think like.
Okay, sorry. Where did you feel that pain when you squatted?
Here.
Which is more, on the inside or the outside?
This side.
On the inside. Yeah. Okay, go ahead, have a seat for me, please. Okay, guys, as you can see over here, so this is what normal is supposed to look like, and we can see here, it's very swollen. This left knee is more swollen than the right. Okay, so we did take x-rays on it, and I'm gonna be very careful with this one. Pain that way, right?
Yeah.
I'm just barely touching it and you're already touching in pain there.
Yeah.
What about this?
Yeah.
Pain that way too, right? Okay, so what I feel right now is I'm normal, I want to feel it nice and stable. But right now, there's too much give. Okay, rock solid here. See, there's loosey-goosey here. So, we check for AIN Femur. And yeah, see, it's not rotating. So, internal rotation is fixated. See, tibia is moving fine. Fibula also moving fine. So there's something going on over here. And then we're going to piece everything start together as well. Now, when I take a look at the knee, right, so on the knee x-ray itself, and as the viewers can see, this is your right. I want to see normal like this. Nice equal joint spaces. Okay? On the left one, we say, hey, what's going on the outside of your left knee? This is less, okay, very arthritic. The surgeons, they operated on here, okay? And this one seems to be decent. Okay. So this is why the surgeons will tell you, says, yeah, you got pain over there? Okay, I think we need to do a knee replacement surgery. And I may have to agree with them, okay? Because right now this is 50-50 because we lost so much of the meniscus over here. And you see all this white stuff over here? It's already arthritic. Normal, as I explained to like the other knee, I want to see like this. There's got to have something here. Okay. So on the outside of the knee, I want to see something here. But however, it's shrunk down so much. You lost about roughly 75% of it. It's gone. Okay. But part of it also the operator on that too.
Yeah.
So, but there's another thing that also tells me that's also another thing that's interesting is where your kneecap is, the patella. Okay. The pointed end is here and here on the outside. Normal, I want to see it smack in the middle. This needs to be smack in the middle. So what's causing this to go outside that way? We have certain nerves in our low back. Most commonly the fourth lumbar nerve. It needs to go down into over here, the vastus malleus oblique muscle. That's this muscle right over here, on the inside part over here.
Yeah.
So if you don't have enough nerve function here, what's to pull that kneecap in the middle? Nothing. Whereas the outside of your knee, those muscles are still working, so it's still grabbing. So it's gonna pull your kneecap away from it. So this tells me, okay, we have a potential fourth lumbar vertebrae and a nerve that's in trouble that we need to investigate on the full spine. Okay. Now, over here, okay, we take a look at in the big picture, and we can see it says, yeah, this spine, there's some kind of interesting instability. And when we take a look at the foundation itself, now things make a lot more sense. Why you got that knee trouble in the first place. This line over here is supposed to be in the middle. But because it's way off to the side, that tells me your haunted pelvis is going like this. Okay? So since you're going this way, what's it gonna do to your knee? Your knee's also gonna twist. If this pelvis is rotating this way, what's it doing to the knee? What's it doing to your left knee?
Rotating.
Not only rotating, but you're also putting weight on the outside of that knee. So what is going to happen to the outside of that left knee? You're going to feel pain there.
Yeah.
right? And it's gonna wear it out over here, right? So the real answer is, hey, we gotta untwist it, get you over here. And that's how we get those things leveled, okay? Therefore, with that twist, okay, that's one component. Another thing the viewers can also see is your whole entire pelvis is sinking down on the right hand side. So that's what tells us, okay, we have ends also taller on here, shorter on here. So this tells me, it says, okay, we have a PIX type of misalignment. Your pelvis over here, what happens, it went this way and that way. And also, it causes the pelvis sink out this way as well. All right, that's why we see everything sink out this way. But since your whole entire body is sinking like this way and that way, there is no way you're gonna walk like that way, okay? Your body gotta recompensate. So that's what happened over here. Your number 4 vertebrae, instead of following along, sinking down this way, it adapted going this direction. The problem with that is because it gapped open like this. Since it gapped open this way, it's gonna swell up and start irritating the nerve going down to that left knee. And also to the right knee as well.
Yep.
All right, so we got that aspect. Another that helps confirm this rotation and that tells us this is not new, this is very old, is here. You have a lot of arthritis here. So when your whole entire pelvis is going this way, I'm simplifying so because this is actually in 3 dimensions, but in 1 dimension, you see like twisted this way. And you're not walking this way. Your body has to compensate, rotate this way. And you're still walking, so you're still going like this. So every time you keep on twisting your body while you're walking, because when we walk, we're always walking like this,
Yeah.
right? So therefore, in this position, and you're walking like this, you keep on twisting like this way, it's gonna wear out on the right side. So that's when we see a lot of arthritic changes here. So the amount of arthritis, just like a door that like sagged and started rubbing against the door frame, the amount of damage I see here tells me, oh, this is about 15, 20 years worth of damage here. That tells me this thing's been there for at least 15, 20 years or more. So this is not a new injury, this is a very old injury. And because it's been there for so long, that's had that domino effect. Kept on doing like that to your knee's like bent out this way. That knee eventually, the meniscus keep on wearing out to the point that over here, kept on wearing out so much that way, wears this out, boom. Can't take it anymore. The body says, okay, you're not doing anything about this, we're gonna pull on the brake, check engine light is now blinking. It's now on. We gotta take care of this, all right? So that's what the strategy is gonna be in your case. I'm gonna investigate a much more closer look during examination, what's going on with this left hip over here and that 4th lumbar vertebrae. Everything else, we'll keep an eye on it, see what's going on, but we have several potentials, okay? With this mid dorsal over here, that 2nd dorsal, and that, and that 6th or 5th cervical. Well, most likely that 5th cervical, right? Okay, we're gonna do an inspection. Okay, so we're always looking for is any areas of swelling, muscle spasms. That gives it an indication and ideas of where the body's trying to stabilize something. Okay, so I'm identifying. Okay, we got something swollen and tight over here. A lot of it. There's some pitting edema right over here at this level, so we're gonna mark that. That edematous fluid area. See, well, no, right there. Come on, tracing that. And we already see something just like one speed bump over here, and there it is. It's the 4th lumbar. Keep on going down. Pain tender right here?
A little bit.
A little bit, right? How's this one?
Yeah. This one.
Which one's more, the left or the right?
The left.
Yeah. See, there's some fluid over here. Okay, puffiness right on the top of the SI joint and also the inside of it. So this helps confirm because when the hip itself starts moving away, as it does in a PI ilium, posterior inferior words, because it's gapped open this way, that's why there's going to be fluid built over here. Okay, and then when it goes external rotate this way, it opens up a gap over here, and then there's going to be fluid build up on the inside of that joint as well. So that's what we're looking for this one, and we confirmed it. Okay, we got something over there, but we're not going to rely on just one indicator. Now we're going to go to other indicators as well. So with the instrument device, this could help once again confirm potential levels. But actually, the more important function for this device is also helps confirm that on multiple visits, it tells us when to stop adjusting these joints. Because ideally, we don't want to keep on adjusting this thing all the time. As the saying goes, if it ain't broke, don't fix it. So if it's healing, we don't want to just re-aggravate it and cause a new fresh injury when the scar tissue is healing up. So this tells us potential areas. Right there. Okay, so now we're going to assess your foundation. Now, you feel that right there?
Yeah.
It's not moving at all. It's completely stuck in external rotation. See, your right side, at the pivot, swings just fine.
Yeah.
Sacrum. Okay, that's decent. So your 5 is moving. Feel that right there?
Mm-hmm.
Yeah, that's a 4. That's not moving at all.
Okay.
See, now this is all arthritic. That's why this is hard as a rock. But my expectation is after we adjust this, this should start loosening up over here. See as well? This is also very bad compensation. And then this one. Second dorsal, it's moderate fixation, but not too bad. And this one here as well. All right, we're gonna tackle the major ones. Now we're doing the push maneuver instead of the traditional pull, is because all his vertebrae over here on the lumbar spine is all rotated towards the right. So if we do a pull maneuver, it's going to make the spinuses rotate even further to the right, and that's what we want to avoid. So when we do a push maneuver, it's going to recenter. Instead of everything rotated to the right like this, it's going to move it more in center line. So follow over here. Alex is over here. Okay, walk around a bit. Okay, come on. Walk around a little bit.
Oh, like.
Sure, just walk. Tell me, do you notice anything different on that left knee?
Yeah, I feel a little bit less of
What's a little bit less?
the pain.
Okay. Any other changes you notice in the left knee?
Oh.
Touch it. Try to do a little squat.
Oh yeah. Yeah. Wow. Yeah. I can do it right now. Before, no.
We definitely saw that before. You couldn't do that. So how much better would you say right now for that left knee?
Pain?
Anything.
Oh. Well, I feel better. I feel like, I think like maybe 2 or 3 on the pain, the like level of the
Okay. Where were you before?
9.
9, and it went all down to a 2.
Yeah.
Hey, that's great. 2
Yeah.
or 3. Hey, that's really great. Okay, let's do some more. Okay, let's go ahead. Let's restore some more nerve function to the knee itself.
Okay.
Lumbar. Okay, relax shoulders. Now it's very key for the patient to relax his shoulders, because if this is tensed up, then the muscles here and the ligaments also tense up too and will not allow a proper set. So now we're assessing, we're finding out where is this liquid ball bearing, the nucleus pulposus, where did it go? And it's right here at this angle, and now we're going to set it. We're going to realign it, recenter it, reposition the vertebrae back onto the nucleus pulposus like that. We hold on to it, so let the body readapt to where it is going to be. Restore more nerve function to the knees. We're going to bring them up.
Yeah.
Okay. Go ahead, do a squat. See how it feels down.
Yeah. It's better if I feel here.
Okay. So what's different from before, from the previous adjustment to this one?
But this is better, like, yeah, I feel like I can do more squats.
So you could do a better squat.
Yeah, better.
Okay, that's great. As we pointed out earlier, okay, we did the assessment. It's still flinching, still
Yeah,
in
yeah.
there, right?
Mm-hmm.
And that's what I still see as well. It's a little more stable, but it's still, the knee itself is still misaligned. And this is still an AIN femur. Pain right there, right?
Yeah.
So what we're doing right now is, because it's swollen right here at the median meniscus, we're gonna pump that up. We're gonna gently nudge that meniscus back into its place. All we're gonna do is we just simply just like put pressure right there and wait for that fella just to slurp back into alignment. And it may take some time. Feel that little fella?
Mm-hmm.
Yeah. Now we're gonna check the other one. Even your lateral one is also slightly out. But there isn't that much because, again, you know, these operate on this one. So I'm not expecting too much of a big swelling. Not like your medial meniscus. So again, we're just gonna just gently nudge that fella in place. And then we're gonna start pumping this before we set this knee. So first things first. Now, it's very vital before we do any extremities, especially in an acute knee pain like this, we have to get the adenomous fluid out of the way. Now, if we didn't and we try to set this, it's sort of like trying to jam an oversized truck underneath a parkway bridge. The truck's just gonna slam right underneath the bridge itself. That's not gonna be fun. Whereas the more smarter thing is, right, we're just gonna lower the height of the truck, such as deflating the tires a bit. Okay, the same thing. That's what we're doing over here. We're trying to get some of that fluid out of the way so we can prepare this joint and tell the body where the normal alignment is supposed to be. So I gotta keep on doing this until I feel just enough of that give. And that's what we got for this medial meniscus. We do the same thing for the lateral meniscus. Yeah, I know, see. So we're gonna pump this even more. Okay, we still need to do some more work on this before we set both. There it goes. Now this fellow is ready to be set. We're gonna be very gentle on this one. Okay, so we're gonna traction the leg out a little bit, give it a little more space, pump it up a bit before I set this femur over here into proper alignment. Now it's still swollen a bit, okay? Let it go, relax. There it is. That was a nice little set. Yeah, go ahead, walk around, sir.
Yeah, better.
Okay, go ahead. Do a squat.
Next question.
Go for it.
Yeah. Most better. Yeah. Feel pain, but less.
Okay.
Like more than the 50% less.
So overall, 50% less.
Yeah.
From before.
Yeah,
till
from
now.
before, yeah.
Okay. All right, that's a great start. So here's what you do, okay? We're making great headways. It's still, as the viewers can see, this bulge, this fellow's swollen, okay? And you also got some chronic swelling over here as well. I need the ice over there, 20 minutes every 2 hours. Pump that fluid out of the way. We'll see you in the next visit and let's see how that knee's coming about.
Okay.
All right? Okay, that'll be it for today, my friend.
Yeah, thanks.
Oh, you're welcome. All right, so give us the latest updates. How's the left knee doing so far?
Well, I think it's better, but no like I want to.
Okay.
Yeah.
All right, so how much better would you say from before to
For
now?
the last one, I'm here, like, I think now I feel like 4, the pain.
So-
So 10.
All right, that's
Before, when I was here, it was like 10.
Mhm.
Now it's like 4,
down
5.
to 4.
Yeah.
Hey, that's a great
Yes.
improvement. So, but also the viewers are not aware of it's also raining outside, so that's also contributed to some of that discomfort because of the change of barometric pressure. It's like sucking some of that damaged tissue out of the out and aggravating some of the discomfort. So continue icing up over there. All right. Thanks for the updates, and we'll keep working on that. All right.